Hi, everyone. So nice to see such strong attendance. So great. So I'm going to be presenting for about 20 minutes. This topic could probably take us an hour of didactic followed by an hour-long case discussion. So hopefully we'll have enough time to give a flavor of approaches to management and a good case discussion opportunity. So for the talk itself, the learning objectives will be, we're hoping you'll come away with the ability to identify the clinical use and safer prescribing practices for benzodiazepines, understand the risks associated with long-term benzodiazepine use, discuss alternative treatments to benzos, and describe how to design a benzodiazepine taper for people who have been prescribed benzos for an extended period of time. So I just want to note that the focus of the talk today is not on management of benzodiazepine use disorder itself, but around safer prescribing and taper strategies in general, though we will be touching on benzodiazepine use disorder as well at times in the talk. So when we talk about benzos, that's a class of sedative drugs that are widely used across North America. That includes benzodiazepines. They're analogs, so we hear a lot about analogs in the contaminated drug supply, such as atizolam, and then benzodiazepine-like drugs, which are pharmaceutical-grade available products like Z drugs, so zopiclone or zolpidem would be in the same class. And in terms of just some national data and prevalence of use, approximately 10% of Canadians over the age of 15 have reported that they've used a prescribed or non-prescribed sedative in the past year, so about 1 in 10. And within BC, it's the prevalence of prescriptions is about 400 to 500 per 1,000 population, which is just slightly below the national average. So benzodiazepines are approved for some chronic conditions, for example, epilepsy, severe generalized anxiety disorder, though typically use is only required for short-term symptomatic treatment rather than long-term use. And we'd be thinking about long-term use when we're getting into 4 weeks or greater prescription durations. So there currently is no substantial evidence that suggests that long-term benzodiazepine use beyond that period of time is clinically effective for commonly prescribed conditions such as insomnia or anxiety. There are some exceptions to that, of course, but in general, they're not often indicated as first line. Most initial benzodiazepine prescription indications recommend short prescription duration, frequent patient reassessment, and avoiding automatic prescription renewals, but actually we're checking in with patients before each prescription. So approved indications vary by the drug and by symptom, but commonly seen indications for benzodiazepine prescribing are in the setting of acute alcohol withdrawal, so that kind of early 7-day period, severe acute anxiety, transient or short-term insomnia as adjunctive therapy during initiation of an antidepressant medication, so the first days to weeks of starting an SSRI, for example. Mild to moderate acute anxiety, so less than 2 to 3 month periods, muscle spasms in the acute phase as well, and acute seizure and seizure disorders. Long-term use of benzodiazepines in particular, unfortunately, are associated with a number of risks. Documented risks include increased risk for confusion and disorientation and potential persistent memory or other neurocognitive deficits, falls, accidents and injuries, motor vehicle collisions, risk for development of sedative use disorder, among a few other potential risks. And the risks and side effects of benzodiazepines increase with the duration of use, escalating doses, and then use in combination of other drugs, particularly other sedating medications. They do have a high potential for non-medical use, and physical dependence can develop quickly. So benzodiazepine use alongside other central nervous system depressants, so that would be including opioids and alcohol, significantly increases the risk of respiratory depression, drug poisoning, and death. There is an association among people using benzodiazepines and unregulated drugs with hepatitis C, HIV, and mortality. And data from the provincial overdose cohort in BC that looked at prescription-related risk factors for non-fatal opioid-related drug poisoning showed that benzodiazepine prescriptions were associated with an increased odds of non-fatal drug poisoning events. Benzodiazepine receptor agonist prescribing, therefore, should be particularly either avoided or very thoughtfully considered in the case of folks with alcohol, opioid, or other substance use disorders, in the case of older adults, so over 65, in the case of individuals taking other sedating agents, such as opioids, gabapentinoids, tricyclic antidepressants, muscle relaxants, because of that increased risk and synergy between those medications with benzodiazepines with risk for respiratory depression and death. We did want to make a comment about benzodiazepine contamination of the drug supply, given that it is such a huge issue right now. We don't have a lot of direct clinical guidance in terms of management of this issue, but we want to acknowledge it because of its prevalence. Like I often staff the 24/7 addiction line, and I do get a lot of calls related to this situation, as well as seizure events from people who abruptly discontinue use of the illicit drug supply. So inadvertent exposure to benzos in the toxic drug supply is definitely a challenge when managing opioid use disorder. It used to be that there was a relative contraindication between prescribing of benzos and opioid agonist treatment, though it is now recommended that we would never delay initiation of opioid agonist treatment medication for folks who are on benzos or exposed to benzodiazepines. And we would recommend that when people are stabilized on opioid agonist treatment, we review indications for co-prescribed benzos, work with patients around safe and supportive tapers as appropriate. In many cases, there are safer alternatives to benzodiazepines that can be considered, particularly in the cases of anxiety and insomnia. So clinicians really should work collaboratively with the patient to develop both short and long-term treatment plans. So it's important for clinicians to understand the realities of receiving treatment for anxiety, including wait lists, length of time it can take to find an effective SSRI dose for an individual, both of which can delay relief for that person. These can be prescribed in the acute phase for stabilization for anxiety disorders, but generally, ideally would be avoided for longer term use. In the case of insomnia, other first-line treatments include CBT as preferred first-line therapy. Benzodiazepine receptor agonists would be avoided as first-line, particularly in older adults, and if used would be aimed to be for short-term, such as less than 4-week adjunct medications, and with avoidance of long-term use for the indication for insomnia. Anxiety and insomnia may be signs of an underlying issue such as pain or trauma or psychiatric or substance use disorder. A comprehensive medical assessment should be conducted to confirm or exclude other causes of these symptoms, with specialist consultation as appropriate. So frequent reassessments and working with patients in a patient-centered way. In terms of tapering, benzodiazepine taper is usually safe in outpatient primary care settings. Deprescribing strategies include tapering or gradually reducing the benzodiazepine dose to 0, taking benzodiazepines only as needed during acute events, so such as PRN prescribing, using a lower benzodiazepine dose as needed compared to baseline prescription, offering behavioral interventions such as brief intervention and CBT, involving educational and motivational tools to support understanding and acceptability of tapering process, and referring to psychiatrist or psychologist if underlying psychiatric disorder exists to discuss and help plan for successful benzodiazepine deprescribing. And just to say, we'll probably in the discussion talk about in more detail about tapering approaches, but one of the key principles is that they should be individualized and based on how patients are doing along the course of the taper with frequent reassessments. So there may be situations where risks or potential harms of tapering actually outweigh the objective benefits of tapering. And so there needs to be careful reassessment during the course of that effort with patients. So the College of Family Physicians of Canada has developed an evidence-based guideline and algorithm for deprescribing benzodiazepines. And clinicians and people accessing care may benefit from the Ashton Manual, which provides a comprehensive examination of long-term benzodiazepine use and withdrawal. So this manual is primarily based on in-depth clinical experience rather than being strongly evidence-based, but is probably the most commonly used approach that clinicians use when coming up with a strategy to do a supported taper. It may be a useful reference. So when designing a taper, a plan should be created ideally for the taper before the initiation of benzodiazepines. So the ideal rate of tapering benzos in outpatient settings, it hasn't really been clearly established, and there is appropriate that there be considerable variability in terms of withdrawal symptoms. So the type of benzodiazepine that's selected, the dose that's selected, and the duration of the taper can vary considerably based on patients and how they're doing during the course of that taper. In general, the key principles to consider when planning for a taper is to use a person-centered approach to develop an individually tailored plan that includes collaborative decision-making at each stage that involves the person receiving care and, if appropriate and wanted, their family. Gradual and flexible benzodiazepine dose reduction, where individuals are reassessed following each dose reduction. So individuals should expect, I'd say the most common scenario is that benzos can take some time. They can take as long as 12 months or more, depending on the clinical situation. A general rule of thumb for the taper rate would be a dosage decrease by approximately 10 to 25% every 1 to 2 weeks or monthly is often a strategy that will allow for a gradual reduction in dosing in a way that's well tolerated for the patient. It's critical that at each assessment, input from the person receiving the care is taken into account when designing the taper schedule, and that it be adjusted depending on how they're doing along the way. It is appropriate to slow down the dose reductions if people are finding that it's challenging or they are symptomatic, or to hold or pause the direction of the taper along the way, depending on how patients are feeling. So this is a framework called the taper framework, and it offers an evidence-based structured approach to deprescribing that may be beneficial for clinicians. It's an acronym that stands for assessing medication use, talking about risks versus benefits, selecting alternatives, and planning next steps, as well as engaging the person receiving care and reducing the dose. So you'll notice that engagement is listed down lower at the end of the acronym, but at all stages of working with a patient on a benzodiazepine taper, they should be engagement and relationship building. So in terms of monitoring during a taper, return of symptoms including insomnia and anxiety, as well as I find sometimes bizarre or unpredictable symptoms like paresthesias and other rare symptoms can be noted by the patient. Most commonly, anxiety and insomnia are reported. Typically, insomnia is mild and usually resolves within the year. In the event of insomnia return, clinical reassessment should occur monthly until insomnia is either resolved or stable, and then regularly every 6 months ongoing. And psychological and behavioral interventions, such as relaxation therapy or CBT, are recommended for return to insomnia. Reducing benzos can unmask a previously undiagnosed anxiety disorder. So that's really important to be vigilant about during a taper. So in the event of a previously undiagnosed anxiety disorder, clinicians can offer treatment which includes psychological as well as pharmacological options in line with the Canadian Clinical Practice Guidelines. While rare, seizures are possible in patients with underlying seizure disorders or with abrupt discontinuation of high benzodiazepine doses. So abrupt discontinuation should be avoided with high doses given risks of severe withdrawal, including seizures. Along the way, offering of adjunctive therapies can be considered to support some of the mild withdrawal symptoms if patients are engaged in wishing to continue with the taper. Common medications that can be used briefly for this include gabapentinoids or valproic acid. So in summary, benzodiazepine receptor agonists are typically indicated for short-term use rather than long-term use. There are numerous risks associated with benzodiazepines that increase with duration of use, escalating dose, and use in combination with other drugs. So they should be carefully considered in terms of what the duration of treatment will be and what the taper strategy will be prior to initiating a benzodiazepine for a patient. Safer prescribing practices for benzodiazepines include considerations for specific populations, individuals with other conditions, including anxiety disorders and others, and consider alternatives prior to prescribing benzodiazepines where possible. And when tapering, they should be gradual, flexible, and person-centered. I will stop there. Thank you.